Good morning.
Good morning.
How are you?
I'm having technical difficulty. I don't know what's going on.
Uh-oh.
I don't.
Uh-oh.
All right, but how are you?
I'm good. What's happening?
I went live, but it's not showing up on Instagram. So I just canceled it. I'll just go on YouTube.
Okay. Oh no. Did you keep the screen open? I mean, look, you told me how to do it, so I know you know how to do it. Can you just redo it?
The same thing happened last week. I don't know what's going on.
Really?
Because you know how like as soon as you as soon as you hit this, go live,
Hmm.
you'll get a note. I got a notification that you went live, but when I started mine, I didn't get a notification. And you know how you had that little live thing, the icon that flashes? That's not even flashing.
Oh.
But I see it came up for YouTube, but that's all
Yeah, I
right.
see you on YouTube.
That's how technology does sometimes, I guess.
Well, how was your week?
It's okay, It's just it's just weird. I don't know what's going on. But I got a different color shirt.
I see. Now, what color is your shirt today? No, I'm kidding.
It's look, according to the receipt, it's heather blue.
All right, receipt. Receipts. You know, we always about the receipts.
Does it look blue? Because last week I was way off. I'm
I
like,
know. I was like, sir, did you look down and see what you had on? I don't
see.
know. We see it. Do you see it? I know you see it. Hey, I know you see it. They itty bitty. Okay. Anyway, welcome everybody to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information, news, education, certification tips, technology, the color of fabric,
Yes.
all of the things, as well as entrepreneurship. We also just primarily discuss the revenue cycle in its entirety at large. As you come in, don't forget to hit the thumbs up or like button. Yes, yes, yes. I am Clarice Warner. I am the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. I feel like I sound like Barry White. I don't understand. Anyway, PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Well, before I introduce my co host to the world, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Oh. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, we'll check the video description for the link. So joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been in healthcare for a very long time, 20 plus years. And I left the bedside in 2014. I started in risk adjustment and really liked it. And during the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is that going?
It's coming along nicely.
Good, good. Yes, yes. I'm so excited for you. All right. So before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Your opinion matters and is welcomed here. So use the chat in whatever platform that you are viewing us on or listening to us on. Uh, yeah, use the chat. If you have a question, the only thing that we ask is that you put a Q first so we know that it is a question for us and you're not just talking amongst yourselves, which you can always do. We love to see the chatter and the banter amongst the
Yes.
folks. All right. So for those who are just joining us or watching the replay, today we are talking about the 2025 April edition of the ICD-10-CM updates. And there are some critical coding changes that may impact you and yours. But first, let's get into our church announcements, shall we? Yes, we shall. Hey, hey, hey. I like your little green. I like your Martin Luther King green banner. I think I was real serious when I did yours. This one, it was like, I need one. I need one. Oh, and I was, where was I? I was in some program the other day, and the lady, oh, it was a guy. It was actually, now that I forgot, it was a memorial service, but it was supposed to have been like, it was a celebration of life, and she was going to do this service regardless to tell her story. And she had a gentleman that was a saxophone player there, and then the lady got on the organ, and I just started recording. I was like, I don't want to mess up, have all of the stuff blocked, but we gonna play some of that one day. It was all of the things that I needed the organ to with some sax on it. With some sax on it. It was great. Okay. Oh, it is. Yes. Yeah. Okay. It just hit my spirit just a little bit there. So, announcement for today. Well, if you didn't know, tomorrow, March 30th, 2025, is National Doctors Day.
I didn't know that.
Yes, yes. We always get a little taste of it every year. I think it's the last Saturday or last Sunday in March. I believe. I don't, or is it a specific day? Maybe it's a specific day. Maybe it's specific to March 30th. That I need to research, but I know we get a little bit of it in every year. And just, I know some fantastic doctors, and I'm sure you all know some fantastic doctors as well. And if you do, feel free to shout them out in the chat. But I wanted to talk a little bit about how some doctors, fantastic or not, are running the social media to complain about things. So I saw an article about titled "A Social Media Complaint Gone Wrong" by Ronald Hirsch. And you know, Ronald Hirsch is always very animated and insightful. I'll say that, insightful with his articles. But so a surgeon actually was upset because, and I think it's a female surgeon, was pulled out. Yes, a female surgeon was pulled out of her surgery, out of the operating room, to talk to an insurance company medical director about getting her patient's overnight recovery approved as inpatient care. Now, I probably would have been in my feelings too, because I'm working
Right.
on some delicate things and trying to make sure, I'm trying to stay focused on what is happening. And then have to be pulled out, which, violates the sterile atmosphere that has been created and all of the things. in order to provide information necessary to get this stay covered. So in his article, of course, he mentions that really that was a failure on the part of the hospital's utilization review, because they were supposed to make sure all of those things happened prior to. There should be no reason why somebody was tapping the surgeon on her shoulder as she's performing this mastectomy and breast reconstruction to talk to them about getting this patient's but the surgeon went to social media, talked about that. Well, the surgeon has come back. I think she probably got a lot of empathy. A lot of folks was like, "What? You know how people do." Well, she's gone back to social media and just talking about the same patient, but the patient came back with she came through the ED with chest pain, shortness of breath, several weeks after the surgery, and was diagnosed with a pulmonary embolus. She was complaining now because the insurance would not approve the admission. Again, in his article, we don't have the documentation, so we don't know all of the facts. We only getting one side of what the situation is. But the problem is this ER or ED visit happened shortly after your surgery. And you putting all of this information and conversation out on social media. A legal nurse came in and asked, you're providing all this information. Are you violating some patient privacy laws here? Number one. Now, of course, I'm sure there was no name or anything mentioned regarding the patient, but a lot of folks can put two and two together, particularly those who have been involved in this particular case and know, the ins and outs. But then secondly, are you opening yourself up now to medical liability because the patient may or may not have received appropriate care after her surgery? So it's like, sometimes it's all right to vent at home, sometimes it's all right to keep things close, right? Everybody ain't got to know everything all the time. And, I don't know. I mean, I know folks like to get attention is the drug of choice of late. And, but sometimes that attention can hurt you. Mr. Jesse, did you have any?
I actually do.
I thought you would.
The thing that I don't understand, because this doctor, I mean, well, I didn't read the article, but I'm sure this lady is intelligent enough to not give up any patient identifiable information.
Uh-huh.
So that's number one. Number two, I don't see how the insurance company could want to deny this admission related to a complication when it could be put on them that they caused the complication. Because if she had to leave the room to go answer a call, because I was thinking the whole time, like, this is putting the patient at risk for anything could happen.
Absolutely.
Which apparently something did. So I don't know. This one is very, very interesting, and I'm siding with the doctor on this one, and I think that they can't say, because I'm sure because it's a complication, no insurance company would want to ideally pay for it. But
right.
How can you say that her having to leave the OR didn't cause it? So
yeah, so it's a whole hot mess. Just some food for thought on this Doctor's Day Eve. Again, sometimes it's okay to keep things just close. Share it amongst your friends. Talk amongst yourselves. Everybody ain't got to know. So yeah, I found that article very, very, very interesting. As surgeon out here, and I mean, it's your page is your whatever. And it didn't say where she was on social media providing the information. But yeah, I thought that was really interesting. So,
Now I'm all for discretion, but I don't know. I'm just something is saying to me that her making this post actually may work in her favor, because people know that she had to leave the OR to speak to which is crazy to me, but if that's what she had to do, I don't see how they could put that complication solely on her and then try to deny any kind of subsequent care. This is going to be interesting to follow if we're able to.
Well, I put the link of the article in the chat, so feel free to check it out. Mr. Jesse, do you have any church announcements?
I only have one that I stumbled across this week. The National Cancer Registrars Association, they are the people that have the Cancer Tumor Registrar certification. Did you know that last year, January 1st, they changed the name of the certification?
No.
So
but I've heard a whole bunch of different things going on over there, but you know.
Well, January 1st, 2024, the CTR changed to Oncology Data Specialist.
Okay.
And they have it, and I went to their page, they have a whole nice little PDF of like eligibility and, you know, ways you can meet eligibility to sit for the exam. Like, and this also just reflects, as we always talk about, the age of information, because oncology data specialist is more in line, in my mind, with just data analysis, period, which really that's what a certified tumor registrar was all along, but that gives it a more modern name, I think. So that's
is it the first time the name has ever been changed, or is it
from what I don't know, but I just, because I mean I've just heard CTR forever, so I don't know.
Forever. Yeah, I remember vaguely hearing there was some grumblings about something going on over there, and it wasn't the name change, it's something else. I don't know if it's something, I don't know if it's financial, or is it something related to the certification exam itself? It was some grumbling I've heard.
Because I didn't look up the CTR requirements, but this ODS certification, you have to have a degree. So I don't know what it was.
Maybe that's what I don't know. Maybe that's what it was, because I know I just remember recently hearing some grumbling, like, okay.
But what was interesting in there, I didn't even know that they had this NCRA approved programs. They have the NCRA approved bachelor's and associate programs. But if you have any associates, you can also take, they have a practicum.
Okay.
To meet eligibility for the exam.
Okay. So people, and now I've always heard that the information in the program was quite rigorous. I've always heard that. But for those that may be interested in, you know, so do we need to say oncology data specialist instead of tumor registry?
Yes.
Or are they going to change the registry part of it? I mean, I don't know what that looks like. If you were interested in that kind of data, because you're right, they are abstracting and collecting volumes of data on patients, because they begin, and trauma the same way. So it's trauma. Well, trauma is different.
Yeah.
But it's the same premise, just a different certification, I guess. But once that person has been assigned, in this case, you know, with some sort of neoplasm, primarily a cancerous neoplasm, then these specialists will begin to follow and document and collect the data and information about this patient all the way through their course. So yeah, it's a lot going on, and they're very meticulous. You know, I've sat and listened to several sessions on all of the things that they have to do and all of the things that they need to know. So yeah, it's a little special group of folks on their own, in their own right. So yeah. Well, thank you for that.
Mhm.
No other church announcements?
Oh, I have a I have a new ICD-10-CM class starting on Thursday, April 17th. If anybody's interested, visit thecodingnurse.com for more information.
Hey, all right then. All right. It was like, I only got one. Like, sir, no, you have two. All right, all right. Let's see. Everybody quiet today. Okay. Well, let the tea spilling begin. Let the tea spilling begin. So, for those who I haven't addressed already, welcome again to the Saturday morning tea. And today we're going to talk about the April 1st, 2025 ICD-10-CM updates. And I talked to you all before when we talked about what was happening with PCS. And there were no new codes per se that came out in this particular update, but a lot of things happening and a lot of things going on. So, yeah. So these mid-year updates might not introduce new codes, but they bring significant changes to how you look up codes in the index, because there are some index changes. Some of the tabular instructions have been modified and updated. And then the coding guidelines that will directly impact your coding accuracy and reimbursement. And so we know staying current with these updates can be challenging. We all know that when you're already managing a whole bunch of things within your daily workload. But that's why we're here, to help you break down everything so that you can be prepared. Should have already been prepared, but be prepared for what's on the horizon next week when you walk through the doors. So hopefully you got your favorite cup of tea or your drink of choice, whatever that may be. There's no judgment here. It's 5 o'clock somewhere, so somebody may be doing some other thing. So let's dive into these critical coding updates. So again, let me clarify what these April updates actually contain. While there are no new diagnosis codes, as I mentioned, we're seeing important modifications to index entries, tabular instructions, and the official guidelines. The updates touch on several key areas, including COVID-19 coding, obesity classification, and a significant change to viral myocarditis coding that also could impact your facility's revenue. And that one was kind of big. Let's know where you can find these updates. So in the description of the video, wherever you're watching the video, you'll find a link to the CDC website where they have published the complete updates. And you can go there. There are several files. I believe the most comprehensive is the one that says addendum, and you'll find the information there. Again, the files have the guidelines, the index, and the tabular list. So I recommend downloading those files, at least to take a peek at it, to reference to, especially if you're coding in some of these areas that have changes.
No, and even a table of drugs and chemicals.
Yes.
I was looking through that earlier.
Yes. All right. So let's talk about the index to diseases and injuries. You know, those of us who love a good coding manual know to start in the index. So the first significant change affects how we code decreased blood glucose. So previously, if you looked up decreased blood glucose in the index, you were directed to code R73.09, other abnormal glucose. Well, now, when you look up that, you will be directed to E16.2, which is hypoglycemia unspecified. Of course, Mr. Jesse, you know that this makes clinical sense since decreased blood glucose is hypoglycemia. The 3 hypoglycemia level codes introduced in October 2024 were E16.A1, E16.A2, and E16.A3. And they have also been moved to a further level of indentation under these terms. So they're moving you to the appropriate diagnosis for hypoglycemia when you look up decreased blood glucose. And Mr. Jesse, you can jump in whenever.
Okay.
Next, there is a deletion. The index entry for dissection pre-cerebral artery congenital non-ruptured Heartland, previously directed to A9 3.8, has been deleted entirely. For bacterial infections, we see that infection, infective, and bacterial as the cause of a disease classified elsewhere. And Chronobacter, Lord knows I can't say this word, Zakazaki? Yeah, I'm going to say that. Zakazaki. Now points to A49.8. And other bacterial infections of unspecified site instead of B96.89. But the biggest change with real reimbursement implications are what I mentioned before, the index entry for myocarditis and virus, viral. This now directs to code B33.22, which is viral myocarditis, instead of I40.0, infective myocarditis. This is significant because I40.0 is an MCC, which is a major complication or comorbidity, which can substantially impact DRG assignment and reimbursement. B33.22 does not carry this same weight. So facilities can see a decrease in appropriate reimbursement if they aren't aware of this change. And this is a perfect example of why staying current with these updates is so critical for your facility's revenue integrity. And then lastly, there's a spelling correction throughout the index for Girovechi. I guess for a while, they only had one I at the end of the name, and it should actually have 2 I's. So they made that update in the index.
Oh, okay. Can I tell you, I looked at that and I'm like, what's different? I'm like, and look, until you said it, I'm like, I totally missed it because they talk about like pneumocystis pneumonia, but I still I don't know what was going on, but I'm like, I'm not seeing it. And I never even took it to that level to actually.
Well, somebody
Somebody did, yeah.
lasered in, like, wait a minute, hold up.
or spell check.
That too. Or AI did. How about that?
Okay.
How about that? All right, next to the tabular list, there were 8. So this spans 8 different chapters, the changes here. We'll highlight the most significant modifications. So in chapter 1, we see a new use additional code note under tuberculosis. So that's A15 through A19, instructing coders to report cachexia, which is E88.A, when applicable. Similar notes for cachexia have been added to multiple conditions throughout the tabular list. So this emphasis on coding cachexia across multiple conditions suggests increasing recognition of cachexia's clinical significance and impact on patient outcomes. In chapter 11, the excludes one note that prevented reporting K59.0, which is constipation, with K56.41, fecal impaction, has been deleted. This makes clinical sense as these conditions can certainly coexist. An important change appears in Chapter 15 for pregnancy coding. The word uncomplicated was added to clarify encounter for elective termination of pregnancy in the excludes 2 note under category 004. In Chapter 19, we see the excludes 1 note that prohibited reporting birth trauma and obstetric trauma with codes from Chapter 19 was changed to an excludes 2 note. This means you can now report both when clinically appropriate. For intracranial injuries in category S06, there's clarification regarding 7th character assignment. The phrase, except as noted below, was added to highlight that 7th characters, D and S, don't apply to codes with 6 character 7 and 8, which indicate death. And finally, in Chapter 21, code block 094 through 095 or 09A has been updated to the code first obstetric condition instructional note under category Z3A with weeks of gestation. You just nodded.
Okay. Yeah.
Okay. Okay. And then the fun stuff, the guideline updates. So again, I think these probably are the most impactful part of the guideline of these updates, changes to the official coding guidelines, because we always talk about the importance of the guidelines in doing the work that we do. So first, there are significant revisions to the COVID-19 guidelines. So the guideline IC-10-CM, code only confirmed cases, has been edited to remove the phrase or documentation of a positive COVID-19 test result. This is critical because previously a positive COVID-19 test result alone was sufficient to assign code U07.1. Now the guideline specifies that provider documentation confirming COVID-19 infection is required regardless of the test results. The companion guideline for asymptomatic individuals who test positive has also changed dramatically. Before, we were instructed to code these patients as having COVID-19 infection based solely on a positive test. The updated guideline now directs coders to query the provider for confirmation of COVID-19 diagnosis in asymptomatic patients with positive tests. The guideline explicitly acknowledges that false positives are possible, and it's the provider's responsibility to confirm the diagnosis. Again, this is a significant shift in approach, putting the diagnostic confirmation back in the provider's hands rather than relying solely on test results. Good luck with that.
Yeah. Same thing I was thinking.
Next, we have a completely new section of guidelines on obesity coding. It's IC4B, obesity. This relates to the obesity codes introduced in October 2024, particularly the E66.8 series for obesity class. The guideline clarifies that obesity codes can come from categories outside E66, specifically mentioning E88.82, which is obesity due to disruption of MC4R pathway, and 099.21, obesity complicating pregnancy. The most detailed guidance comes in section IC4B1 regarding obesity class coding, which outlines 4 key principles. A 5th character indicating the severity, so you have class 1, 2, or 3, is required. And provider documentation of the obesity class is also required. These codes may be reported alongside other obesity codes to fully describe the condition. If both morbid obesity and class 3 obesity are documented, only code the class 3 obesity as it's more specific. This clarification helps ensure consistent coding of obesity, which has significant implications for risk adjustment and quality measures. All right. That's pretty much what we have as it relates to some of the new things that are occurring for the April 2020 or have occurred and have been published in the April 2025 ICD-10 coding update. Mr. Jesse, did you have any before I do a quick key takeaway summary?
We're just gonna see what happens because
I'm nervous about the reliance on the physician documentation. I mean, there's an educational opportunity there. So folks will need to um, remind providers or complete um, uh, smart phrases or something in the EMR that alerts them that this may be a possibility and check this box or something. So there's going to be some changes related to that. Go ahead.
because I'm also thinking about this morbid obesity, especially like in inpatients. So if the attending says morbid obesity, but um, another specialty says class 3, do you have to query the attending for the class 3? Because it says that you should code it if both are documented because it's more specific. I get that part, but I will have to look it up in the encoder to see if it's going to be an issue or if because those that some of those auditors and inpatient can be really real sticklers.
Mm-hmm.
So would you need to have the attending say that it's class 3, which is going to be even more queries, which is going to piss them off even more.
Well, yeah, it says a fifth character indicating the severity is required. So that, yeah. And then provider documentation of the obesity class is required. So
Because I'm also thinking about like all those bariatric surgeries. That because where I worked, I used to do a lot of those, like maybe 6 or 7 a week.
oh, wow.
So I just could not imagine having to. But the good thing about, well, I don't know, I can't even say that because you always have these specialties that overstep. Like
Always.
if it was just the surgeon, I would be easy peasy. But then you got cardiology, and then sometimes they come up with like, where'd you get that, sir or ma'am? Like,
Mm-hmm.
where'd that come from? Like, just so it's gonna be interesting.
It is. It is. It always is, especially when the new stuff comes out. And so it's like those first several months are like a pilot to see, what the outcomes of all of these changes. And then, I'll never forget when the one year they were getting rid of the inpatient only codes, and with such a debacle, they had to bring them all back. So it's like, wow. I wonder, well, where they're still sitting with that. Like, yeah. Okay. So our key takeaways. Remember the change in viral myocarditis coding from I40.4 to B33.2 will definitely impact your reimbursement since you're losing an MCC. So make sure you review your cases carefully to ensure accurate coding if you're coding in that area. Also with COVID-19 coding, it now requires provider confirmation of the diagnosis, even with a positive test result. So this
But
means
so that was for people who are asymptomatic, right? Okay, all right.
Even with this means developing new query processes for asymptomatic patients with positive tests.
Okay.
And then the new obesity guidelines emphasize the importance of specific documentation. You'll need provider documentation of obesity class to assign the appropriate fifth character. Also, several excludes one notes have been changed to excludes two notes, allowing conditions to be coded together when clinically appropriate. And this could affect how your case mix and severity reporting falls out. And then finally, the new use additional code notes for cachexia, with various conditions highlight the importance of capturing this comorbidity when present. Again, before implementing these changes, I strongly recommend you guys take a look, especially if you're in these coding in these particular areas or coding these particular conditions, to take a look at the files from the CDC website and have that as a reference to guide you on what you need to do and how you need to move. The detailed updates will help you navigate the changes accurately. So let's see. Here's some things that maybe you need to consider regarding some of these changes. How will these changes affect your query practices for COVID-19 patients? Y'all gonna push that off on somebody else, or will you directly have those conversations with the providers? Will you be implementing new query templates for asymptomatic patients with positive test results? What processes will you establish to ensure proper documentation for obesity class coding? And will you need to update your provider education? I just said that. I think there's educational opportunities here all around.
It's going to be interesting because can I tell you, when I was doing inpatient CDI, I never had to query for COVID because the guidelines were like, okay, if it's
You
this
got a
and
test,
that, right? So this is, well, I'm sure because a lot of places inpatient use Epic, so I'm sure Epic has come up with a trusty, dusty template that will go into effect on Monday.
Not trusty dusty. Absolutely. Let's see. How will you implement the viral myocarditis coding change in your facility? And have you estimated the potential reimbursement impact? Because that could be huge, especially if you in your cardiology specialty. That could be big. Everybody gonna be looking like with the big eye when they see some decreased figures than what they were used to. What specific workflows or coding tools need updating with these new guidelines? Will you need to modify any encoders or those cheat sheets that you probably got sticking around all over your desk? And we would love to know, your thoughts on those and what suggestions you may have on implementing these changes in your facilities. I'm sure it will be helpful to those of you who are watching.
I forget the name, but when you said cheat sheet, I'm like, they don't. Where I used to work, they don't call them cheat sheets. They had another name for them, which comes out to be the same thing, but it was just fancy.
Like Tarjay, that's a whole other conversation. Never mind. My bad. A whole other conversation. Whew, yes. So that pretty much sums up what we had today. But Mr. Jesse, I know you sent me several things this week about the impact of the executive orders on healthcare employment. Did you want to speak to any of that? Because it was popping. It was popping.
So I was coming across some interesting things. I mean, because first of all, because I was reading an article and you know how you do a light skim first, then you go back. So when I was reading one of the articles, it said AHA. So I'm thinking American Hospital Association. Well, no, it's because there will be a new agency developed that will encompass the CDC and a few other government agencies, and it's called the Agency for a Healthy America, AHA.
Okay.
Then they were talking about, because I kept hearing these different, I kept hearing 10,000 layoffs. Then I saw somewhere else they were talking about 20,000 layoffs for HHS alone. So it is 20,000, but what they are saying is 10,000 people are going to take early retirement. But then in addition to those 10,000 who take the early retirement, there will be 10,000 more who will be laid off.
Wow.
Yep.
That's a lot.
Yes. Then I saw an article on LinkedIn by Bill Murphy. And he was talking about how these current changes are going to create more opportunity for people to become more highly specialized and drill down. And I'm like, and he talked about data, and he was talking about how CDI could become more impactful, and he used the example, like if they wanted to track um, like post-operative respiratory failure,
Mm.
how that would be able to show um, for the whole risk committee, it would show like the prevalence. And I'm like, um, I was just thinking to myself, like that's a very they're giving CDI, I think, a lot more credit than I think they should in that regard. Because what I'm not understanding is, like, why wouldn't you work with the coders
Right.
for that? Because, like, I'm telling you, like, I'm just so, we've had a good meeting so far, and I always got to take it to the left. But I'm just so over
You're
the.
fine.
I'm
That's
just
why
so
you're here.
I'm just so over these people thinking that these CDI people are like, Navy SEALs, and they're far from it. That's it. And I'm not going to say anymore until the meeting after the meeting. But
Well, yes. All right. Dr. Jasmine. So she mentions, what are we doing Friday night? So on Friday night, uh, my co-host, my partner in success, and I will be uh, sitting on a panel, I guess, if you will, on the High Powered by AHEMA podcast with Dr. J. So feel free to tune in for that. It will premiere on, I think, 8 p.m. Eastern Standard Time,
yes,
7 p.m. Central Time. So all of us know Eastern. So 8 p.m. Check us out. We'll definitely make sure we add the links to all of the places so you can catch that out. So we're excited about the opportunity to join Dr. Jasmine. She sat at our hot seat, so now it's our turn to sit in hers. So
absolutely.
we're excited to have the opportunity to join her and discuss things related to health information. I love your the title, the High Powered Podcast. I love that. That's cute. So,
Definitely.
yes, yes. All right, all right. Well. Let's see what else is going on in the world of health information. Oh, I heard and I don't know, I know you were doing something at one point, or that wasn't you, with the data. Were you doing something? Did you look
Hmm.
at? Okay. So that's coming out. The changes related to their. My understanding is the changes related to their exam. Um, I think they will be piloting that soon, shortly, something.
Which is interesting because they just changed it. I want to say, was it last year? They made a modification to it, and they came out with a new exam prep book and everything.
Mm-hmm.
I'm almost sure because I bought it, and that was when I was talking to the data analytics director.
Mm-hmm. And then I also heard that, which I thought this was appropriate, that with the micro credentials, like they give you a little information on what it is that you need to know. So maybe I need to circle back because I'm a little confused about them. So initially, I thought the micro credentials were something that you can kind of just add. If you've been in this field and you've been doing this particular job, but don't necessarily have any certification for it, then the micro credential can be something that you can add to say, hey, I am more than proficient in XYZ area. But now that they're coming out with more things, I'm like, well, do we need to change maybe what the thought behind, or what the purpose or the reason for the micro credentials are? Because I understand now that they are actually, let let me step back. So when you go out and you look at the micro credentials, if you're interested in taking those examinations, they give you like a list of all of the things that you possibly should know, but there was no information or no testing or prep information for them, because I guess you should come in knowing these things and take this credential or micro credential exam and you should be good to go. Well, now they're developing kind of prep materials for the various micro credentials. So then that made me think, so is that different? Like, do you now need to learn stuff, or is it, I don't know, more to come.
Exactly.
Because I'm like, well, wait a minute, which way are we going? But I mean, I think it's a good thing, particularly for students who may be interested in coming in and they don't have that actual work history or experience, but they are interested in those type of credentials, and they have the experience from textbook knowledge and the simulations that they've gone through using the various electronic tools that we all use. So, I mean, I'm gung-ho, and it helps us prepare them. So I'm gung-ho that they are putting those together. But again, it just makes me question, so what were these for again?
Well, what I think would be helpful would be if AHIMA told the industry what these mean. And it would be even more helpful, because it doesn't matter if you could get a micro credential, you can get a micro credential. But if those recruiters don't know what it is and what you can do, it's still going to hamper your ability to get a job, which I think that's the intent of these micro credentials, to show a potential employer, this is a skill set that I have. I have some knowledge of something, which is good. But I just think the industry needs to know so they can adjust these job descriptions.
Okay. She says some micro credentials are an introduction to foundational knowledge to create a pipeline to further education and certifications. So it's not necessarily for the people who've already had or who've already been doing these roles or positions, and they may not have any type of credentials to show that they specialize in those areas. It's primarily for people who may want to, you're telling me more. Other micro credentials are for industry professionals. Okay, so there are two groupings of micro credentials. Other micro credentials are for the industry professionals who want to explore other areas, which also prepare a pipeline to further education and certification. Okay, so in either bucket, a micro credential may suit you for what it is that you're doing. Okay. But to Mr. Jesse's point, it's great for us to be clear and understand. It's crucial for these HR people and other employers to understand and know what those mean. But it's just add some more alphabets, add some more stuff for them to know in selecting the appropriate candidates for these open positions that they seem to have a lot of.
But can't find people.
But can't find people. Okay, yeah. All right.
I have a little story since we have a little bit of time.
Well, tell your story, sir. Tell your story.
Earlier this week, I actually started last week, but this recruiter had contacted me for follow-up for an outpatient CDI position. So outpatient CDI is really nothing but souped up risk adjustment. That's really all it is. So he was saying that another recruiter managed to place somebody in the role. So he said, well, I was just giving you feedback because the hiring manager was really liked your resume and said that you definitely had skills, but she wanted to know if you had outpatient experience using Epic. Which I did, but I told him, I said, well, not in, I said, not in any, meaningful way, but yes, I have. I said, but in a meaningful way, I would say no. And when I said no, I mean length of time, because these people, like, you have to use something for 17 years to demonstrate that you know how to use it. So,
17 years.
I mean, is that not the truth? Like, you
It's
use
the truth. You better
that.
tell the truth, shame the devil. All right.
So we so he goes on, and I said, well, I said, to be perfectly honest, I said, if you know an EMR system, you know an EMR system. I said, now clearly, when you use something, um, outpatient versus inpatient, you use the same EMR, but you may access different information or different parts of the EMR. But
Yes.
if you know how to use it, you know how to use it.
Yes.
Well, he says,
No.
oh, oh, he got spicy.
Oh.
He says, well, this is from a subject matter expert. How would you know? I said, because I'm a subject matter expert too. I said, I'm not saying, I said, I said, well, I don't know where she got her title from. I said, but Ahima told me I was. I said, and secondly, I said, and the reason why I know is because I said that I didn't use it in any measurable way. I said, you didn't ask, maybe it went over your head, maybe you didn't understand what I said. What you should have done was ask for a clarification and assume I didn't know.
Oh my God. I said what I said.
Period.
So how did that go?
So I don't know, because I told him, I said, because first of all, what people don't understand when you start talking about you a subject matter expert in what? Because clearly not Epic, because Epic takes you. That's like you got to be like Navy SEAL 16 to get with Epic. They
Right.
have their whole training. You're not an expert till they say you're an expert, and
Absolutely.
they're the only people who can do training.
Absolutely.
So this is why most people, when every time I've ever been trained on Epic, it was either modules or I had to watch a recording, because nobody hires these Epic certified trainers because they're expensive.
Mm-hmm.
So I kind of cut it off because I was like, see, this is I mean, it's really not that big of a deal, because the bottom line, the position's already full. But don't try
Don't
to
come for me.
exactly.
Don't come for me, amen.
Because the bottom line is like, listen, if you want, me and that chick can go toe to toe.
And we can see who the Shmee really is. How about
There
that?
you go. And because the bottom line is, and this has been my experience, the reason why they want you to know every aspect of the job is because they can't help you. They want you to know because they can't help you, Miss Subject Matter Expert, because they don't know. That's it. That's it. And that's all. Happy Saturday, everybody.
Not that's it. That's all. Happy Saturday. Oh, well, I love it. I love it. See, this is why you should become a member of the PRNT Sippers. That was a perfect segue, sir. Because trust and believe, the meeting after the meeting is going to be something else. So are you thirsty for fresh perspectives on the healthcare revenue cycle? By becoming one of the PRNT sippers, you'll join a community of sharp minds who savor the complexities of the healthcare revenue cycle. Why sip alone when we can sip together and chuckle all the way through? Come, let's spill the tea on industry insights. Here's what you can expect as a valued member of the PRNT sippers. Exclusive healthcare insights. So gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access. Be the first to receive expert insights and guides, ensuring you stay ahead in the ever-evolving healthcare industry. Personalized support. Enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And community connection, which is my personal favorite. Join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network, LLC, a resource that empowers healthcare professionals like you to thrive in your roles, goals, and dreams. So thank you for considering becoming a member of the PRN Tea Sippers. And for the cost of 2 cups of tea per month, you can join the community. So check out the link in the description of the video or go to bit.ly/the PRN Tea Sippers for more information. Your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. Yay. All right. Uh-oh. There we go. Okay. I was like, well, where did we all go? So thank you all again for joining the Saturday morning tea or checking out the replay. Was the tea spilled today? Yes.
Yes.
Put your teacups in the chat. Teacups in the chat. Now, before we sign off, I've got a special request, as I always do, for you amazing viewers. If you found this episode helpful, which it really was, because there's a lot of information that you probably need folks to know, especially your medical coding cohorts, don't keep it to yourself. Share this knowledge with your colleagues by hitting that share button. And hey, why not subscribe to our channel while you're at it? That way you'll never miss a drop of our health information, compliance, revenue cycle, and medical coding tea. Also, if you have thoughts or questions or experiences you want to share, particularly on how you may be implementing the changes that we talked about today, we'd love to hear from you. So drop a comment below and let's keep the conversation brewing. And if you enjoyed this episode, also give us a thumbs up. It helps more healthcare professionals find our content. And we're always looking for new and fresh faces with new and fresh ideas and new and fresh information. Because y'all funny out there. We love it. Also, don't forget to check out the Coding Nurse channel on YouTube and Instagram. Remember, at the Saturday Morning Tea, we're all about building a community of savvy, informed healthcare professionals. So again, like, share, subscribe, and comment, and let's grow this community together. Mr. Jesse, do you have any closing thoughts for the day?
As usual, I'm just grateful that you have created this platform, because nobody is out there talking our talk.
And walking the way we walk, right?
Exactly.
Because we're going to give it to you. The real. All right.
Exactly.
Well, I appreciate that. You're so welcome. I'm glad. I always look at my mom like, yeah, you just love the way his voice was. And that's how we got him. So
I mean, from this, I can't believe this started from Clubhouse.
And I heard they were making some other changes over there. So I still don't know if the changes will allow us to connect again. I don't know. Honestly, I haven't had the time to play. But if they do, then we would definitely bring our Clubhouse brothers and sisters back, because they were funny too. When I tell you, sir and ma'am, a chuckle was had on Clubhouse. All right. So this has been a great session today. See you PRN Tea Sippers at 10:15 a.m. Eastern Standard Time. You should all have your links. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend. Hopefully you get some good weather and enjoy.
Yes. I think it's supposed to be, almost 80 here in Philly.
Well, look at God. Wait a minute. Well, get some natural vitamin D. All right.
According to my sinuses, it will be.
Okay.
Because I am stuffy.
Okay. Look. Well, you heard it here first.
Yeah.
Have a good one.
All right. Bye-bye.
Bye.